Um, Thank you for everybody that's attending. So the purpose of this meeting is just to get some information out there. We're not pushing anything. We have an excellent resource, Rich Meadows, today to kind of talk about how we're doing, and then also answer any questions that you have. I have already forwarded him the ones that I've received in emails, so he has those. We can hopefully get those addressed. So I am recording this video, this meeting. Hopefully it's working. Um, and so what we'll do is we'll open it up. He'll do his presentation and then we'll open it up for questions. But if you have questions along the way, you can either raise your hand, you can do it in the comments, and we'll try to get as much information out there as possible. So to start off, I wanted to give you guys a little bit of how Apollo's doing. Just a few stats, because as almost everybody knows, hopefully by now, because I'm sure almost everybody. Oh, can everybody do me a favor and mute their stuff? Okay, that'll help with the echoey a little bit. All right, so since March of last year to today, we have had 1,148 people that we have tracked and traced. That does not mean that they've tested positive. That does not mean that they were sick. It's either they were in close contact or had symptoms or were sick. Okay, so hopefully that clears that up. Just in July across the company, so in 30 days, 31 days, we had 136 people that were in our tracking and tracing. Okay, that's a lot. In July, we had 3 people that were hospitalized. Of the 136 people, there was only one that I knew of that was vaccinated. Of the 136 people in July, 53 tested positive, 40 tested negative. So we had 68% of those people were tested. But that's a lot, you guys. And of that population in July, 58% of those were from our Kennewick region. Okay, so it's a lot. I know everybody is tired, everybody has COVID fatigue. We're gonna get through this, okay? And part of it is understanding a little bit more about the virus. Okay, so I'm gonna turn it over to Rich. So a little bit about Rich. He has been practicing medicine for 20 years. Okay, he graduated from the University of Washington in 2000. He did his residency at Virginia Commonwealth University from 2000 to 2003.
You just press it as loud as my speakers go.
Okay, can we have everybody mute their mic, please, and thank yous. Um, he's worked in the critical access hospital. He still sees patients, and he has been at Cadillac since 2015 and the chief medical officer of the medical group since 2018. So he has a lot of experience, you guys. He's in the midst of this. So Rich, I'm going to turn this over to you, and then we will open it up for questions and answers as well.
Sounds good. Thanks, Brittany. All right. Well, like Brittany said, I'm a family physician. I've been practicing for 20 years, and I have spent thousands of hours looking into COVID since this whole thing started, because I have to help guide the policies and practices for Cadlick and talk to our own physicians and nurse practitioners, et cetera, about what we're doing and why. So I'm going to give just a little background on current numbers, and these were actually from this morning. So these first few slides are pulled from the Johns Hopkins website, just showing that we have a large volume of infections currently in the United States. Unfortunately, we still lead the world in that. Confirmed deaths are unfortunately over 600,000 from this disease. If you look at confirmed COVID cases per 100,000 people, again, the United States leads that statistic, unfortunately. Thankfully, we don't lead in deaths per 100,000. Brazil has that honor. And if you look at how this is impacting our hospitals and where people are ending up as a result, these are COVID rates and ICU bed occupancy in the US. You can see that we've had some spikes in this, and obviously we're in the midst of a current spike of COVID ICU beds occupied, and that's due to the Delta variant that is about 10 times more infectious than the original strain of coronavirus. In Washington State, where most of us live and care about this, you can see that percentage of COVID ICU beds occupied is even a little bit higher than the overall national average. From a standpoint of the impact on our hospitals, and we're certainly feeling this locally at Cadlick, overall ICU occupancy rate is about 90%, and of that, about 34% is due to COVID infections. Vaccine rates around the country can be seen here, and you can see that Washington is doing better than some states in that regard. In comparison to one of our closest neighbors, Idaho, you can see that our vaccination rate has gone up substantially more than what Idaho's has, and most people are probably aware of the critical standards that Idaho has recently had to employ in northern Idaho because their hospitals are completely full and overrun with serious COVID cases. Again, just showing the impact so people understand where we are with this. COVID hospitalizations in Washington, obviously a very large spike, starting with July going into August. We are starting just now to see maybe a little bit of a flattening of the curve. I hope that's going to hold out, but we don't know that yet. Time will tell. And as far as deaths from COVID in Washington go, you can see where those are the highest rates. And much of this is driven by the total population in those counties, but you can see that our two counties of Benton and Franklin certainly are impacted by this. Again, just in this baseline data, COVID deaths in Washington also significantly up during this period.
Yeah.
And then I would just ask it to make this good for everybody, have people mute themselves.
Can everybody mute themselves?
Thank you. As far as who's getting hospitalized, one thing I want to point out that has changed a bit during this most recent flux of cases is that we're starting to see younger patients getting sick enough to need to be hospitalized. So this last part here you can see is July and August, and some of those age curves, especially in the 20 to 34 range and the 35 to 49 range, have gone up. All right, so that's just a little bit about current state and where we are with the number of infections. I get asked a lot, what is an emergency use authorization on this? I know this has been a concern for people in terms of vaccines. This also applies to therapeutics for COVID. So antivirals that we use in the hospital, monoclonal antibodies that get used in the ambulatory setting, as well as the vaccines. So emergency use authorizations allow the Food and Drug Administration, the FDA, to make a product or a drug when we're in an emergency state. So the criteria, there has to be a public health threat. Obviously, we have that with COVID. There has to be good reason to believe that the product will be effective in either diagnosing, preventing, or treating the illness. There has to be known or potential benefits that outweigh the known or potential risks, and that there are no other adequate, approved, available alternatives at that time. EUAs have actually been in place since 1938, and Project BioShield after the 9/11 activities, and many people may remember we were worried about biologic agents being used against the United States from terrorist groups. This is when EUA really got its start, and then it was used first in 2009 with the swine flu pandemic, and primarily for using Tamiflu in young patients. So how do mRNA vaccines work? I know this is a thing that many people have questions about. So the mRNA vaccine delivers a small piece of protein called a spike protein, and that is then read by the external portion of the cell, not the center where the DNA lives. And this gives instructions to the cell to then produce some of those proteins. Your immune system then responds to those spike proteins as if it were the real virus, producing antibodies and producing memory cells in your body to produce more antibodies in the future. This is a little graphic on how that works. Messenger RNA is genetic material that, again, tells your body how to make proteins, and then your immune system responds to those proteins. The body quickly breaks down the injected material, and so it does not live long-term in your body. The long-term effect is the gain in knowledge by your immune system to be able to produce those antibodies on your own in the future when you're exposed to the virus or a mutation of the virus, like the Delta variant. Viral vector vaccines, which is the Johnson & Johnson vaccine, and this is how most vaccines have been made historically. We inject a small piece of either inactivated or killed virus, and usually that's delivered by a harmless virus like a cold virus. And then your body responds to those proteins, again, to teach your immune system how to make the antibodies and create memory cells to produce more antibodies in the future when you get exposed. And again, your body breaks down those injected materials quickly and they don't stick around. So a little bit on vaccine efficacy. And this is a local perspective. So these are, this first graphic is a real number. This was from yesterday at Cadlic. The graphic below with a little more detail I pulled from a separate day, and in order to protect health information, I have not identified the date on here. I can tell you it was not the 15th, just in case anybody has people that they know in the hospital. So as you can see, we had 251 beds occupied. 76 of them were with COVID positive patients. We had 22 ICU patients, and 9 of them were COVID positive. That actually put our bed occupancy for the ICU at 110%. So we had to move people around to other places in the hospital to take care of them that are not normally intended to be ICU beds. And as you can see, I've got down here listed vaccinated versus not vaccinated. And to be clear on those details, not vaccinated includes partially vaccinated people. So if you've had, one of the 2 doses, or it hasn't been the full 2 weeks since the second dose, it's counted as non-vaccinated because we know it's not fully effective by that point. You can see, and this has been the case for several weeks now, that none of the COVID positive ICU patients are vaccinated. And over the course of time, we track this every single day. About 99% of the COVID positive patients who end up in our ICU are unvaccinated patients. So the next part of this, and I just highlighted a few scientific articles out there. There's many more, but I know we only have 30 minutes, so I put in a few that I thought would hopefully be the most meaningful to people. So one thing that comes up a lot is natural immunity versus vaccine-induced immunity to COVID. Both things do produce immunity. So I don't want people thinking that I'm only saying vaccines are a way to be protected against COVID. Natural infection does give you a level of protection. It's relatively equal to a 2-dose vaccine series. However, there's also very good data that if you take people who have already been infected and they have some natural antibodies to COVID and you then immunize them, they get roughly 2.5 times the protection against a repeat infection. And unfortunately, with the Delta variant, there have been many repeat infections for people. There have been several other studies. This is another one. This was more of a lab-based study that looked at viral and activating protection in test tubes and showed the same thing that the real life study showed out of the workers in Kentucky, and that is that if you compare the immunity induced by either vaccine or infection alone compared to infection and the vaccine, that you get substantially higher titers by doing both things together. And so that is to say, even if you've had the infection, there is still considerable additional benefit from getting the vaccine. There are some additional studies out of Nature articles that show that the memory cells that produce the antibodies gain what's called pluripotency if you've been exposed to both the vaccine and the infection. And what that means is they are more likely to be able to respond to new mutations of the coronavirus that we unfortunately anticipate happening in the future. We don't think Delta is the last variant we're going to see. Side effects. I know that a lot of people worry about side effects from vaccines. So this is a slide out of a study from the New England Journal of Medicine, and it compared seronegative versus seropositive people with vaccination. So seronegative means no prior infection, no evidence of immunity. Seropositive meaning that people have previously been infected and have some antibodies already in their bloodstream. And then this looked at what were the side effects to the vaccines after getting that done. So those side effects are broken out into injection site, so local side effects, as well as systemic side effects. And the blue is the people who previously did not have an infection. The yellow is people who previously were infected. So as you can see, total symptoms from a vaccine is about 60%. Now, the vast majority of those things were from two categories, and that was pain. That's pretty obvious. You get an injection, you're probably going to have some pain with it, and fatigue. And so if you look at that, there is a higher rate of side effects if you have had the infection and then get the vaccine, and that's to be expected. You already have some antibodies on board. You're going to have a more robust immune system response to that. Now, what I'll call out in here is none of the, so in this study, not funded by a drug company or anybody else, there were no serious side effects, no side effects that resulted in hospitalization. There were no deaths as a result of getting the vaccine, whether or not you had previously been infected. I know there's some distrust for the government, the FDA, the CDC. I realize that happens. So I also have looked at things that come from outside the United States to look at that. So the United Kingdom, England, has done a great job of looking at some of these things as well. This is a study out of the Lancet, and it looked at vaccine side effects to two different vaccines, one of which was Pfizer and the other, which is a vaccine not offered in the United States. And their overall conclusion, and this was in over 600,000 patients in the United Kingdom, their overall conclusion was that following this natural study in a community, there were actually fewer side effects, both localized and systemic, from the vaccine than what had been reported in phase 3 trials to get the vaccines approved. And phase 3 trials are, trials that are in humans, and those have been conducted in multiple countries, so not just the United States. Breaking that down into side effects, and I realize the print's pretty small here on this, but you should be able to look at it afterwards. Again, in these 600,000 studied patient, not a single serious side effect that resulted in hospitalization or death from either one of these vaccines. This was, again, not funded by a drug company, and it was done outside the United States and included the Pfizer vaccine. An additional recent study, this came at the end of July, was about people who had an initial serious reaction to the vaccine. Now, overall published rates for significant reactions to the vaccine are up to about 2%, and that includes anaphylaxis or other immediate allergic type responses following vaccination. Usually those happen within the first 30 to 60 minutes. And what was found in this study, they took a few hundred patients who had initially had this serious reaction, multiple sites. So some of these were up in some of these were up in Boston, also Nashville, Tennessee, New Haven, Connecticut, and in Texas, conducted by 4 different groups that worked together on this. And what they found was that even if you take those patients who had a serious initial reaction to an mRNA vaccine, and this was done on both the Pfizer and the Moderna vaccines, that by giving them Benadryl before the second shot, these patients were all able to tolerate actually getting a second shot of the mRNA vaccine that they initially reacted to. Again, just yet another study showing the good safety profile of these vaccines. That is all I prepped for this, and I admittedly put this slide deck together earlier this morning, but on a kind of a tight window here for talking to all of you. And I am at this point happy to answer questions that people have.
So Ryan Willoughby raised his hand, so I think he has a question. And then I have a couple people that have emailed me questions, so I can just read it after Ryan's done. So Ryan, you have the floor.
Dr. Meadows, can you hear me all right? I'm driving.
I can.
So. Okay, awesome. Hey, I just wanted you to maybe touch on if you could compare it to the regular flu. I know you said something along the lines of 35% ICU occupancy due to COVID. How does that compare? You know, because a lot of people just say, oh, it's just a regular flu and it's just another flu shot. Can you roughly compare that?
Yeah, happy to. I'll do my best with that, Ryan. So from a standpoint of seriousness of the disease, obviously flu is a big deal. We still have thousands of people each year that die of the flu. The COVID infection is roughly twice as lethal as the flu. So it's not something out there that's 10, 20, 100 times, but it does have higher rates. If you look at overall risk in the general population, the risk of getting hospitalized as a result of getting COVID is roughly 4%. If you then look at people who are at higher risk, and I'll define that for you in just a second, the overall risk of hospitalization as a result of COVID is about 9%. Now that's substantially higher than what it is with flu. The risk factors that drive this are obesity, diabetes, chronic kidney disease, hypertension, and immunosuppression. And of those, the one that is the most common and therefore probably the most impactful is actually obesity. And then Ryan, I believe you asked about the flu shot as well. So typical flu shots are produced via the viral vector vaccine, the method we've used for over 100 years to vaccinate people, whereas the mRNA vaccine is new and a newer methodology. Effectiveness rates are roughly the same. The mRNA vaccine seems to be slightly more effective than the typical viral vector process.
Cool. So we still have several people with questions. So Andy, you're the next one with your hand up. So. Andy Brasher.
Oh, can you hear me?
Yep. We got you.
Good morning. Thanks for doing this. I really appreciate this. I think it's going to help a lot with some questions our employees have. But
sure.
One of my coworkers is concerned. He has a history of blood clots, and was concerned if the vaccine has any side effects related to that.
Yeah, great question. Did I cut you off? Did you have another question?
No, that's good.
Okay, wonderful. Yeah, so probably everybody heard with the Johnson & Johnson vaccine, there were slightly higher than expected rates of blood clots, especially seen in women under the age of 60. I would say if someone does have a history of blood clots, I probably would recommend getting the mRNA vaccines. There's nothing out there suggesting any higher risk of blood clots with them. I will also add, and this is part of a judgment factor on how likely people think they are to get infected with COVID, and I realize we all make our own kind of best guesses on what that likelihood is. There are significantly increased risks in getting blood clots with the infection. So if you look statistically, at the Johnson & Johnson vaccine, it was not significantly above natural rates compared to placebo. However, if you look at the risk of blood clots with COVID, getting the actual infection, it is significantly above the baseline. And so if you were to compare the risk of getting blood clots from the infection versus getting potentially blood clots from the Johnson & Johnson vaccine, it is significantly higher risk if you got the infection itself.
Cool.
Thank you very
All
much.
right.
You're welcome.
Larry, InScore, you're next.
Hi, can you hear me?
Hi, Larry. I can hear you.
Hi, thanks for doing this. Two things that I hear from most of the guys is one is what is the survival rate of COVID on a percentage base? Do you know?
So let me. I guess it comes down to a couple different things, right? So I'll go back to those overall rates. So an average person, the risk of hospitalization is about 4% with COVID. Higher risk people, and again, driven largely by obesity and diabetes and hypertension, your risk of being hospitalized is about 9%. If you get sick enough to land in the ICU, and that is roughly about 1 to 1.2% of people. If you land in the ICU, your risk of death is over 50%.
Okay, and so that's where I think a lot of guys think with those percentages, why the mandates and the possibility of people losing their livelihood and their jobs if they don't do it. I think that's why, you know, the mistrust of why is this being pushed so hard.
Sure.
Is some of the guys' biggest concerns.
Yeah. So listen, I'm going to answer this as a physician and not a government
absolutely.
official, because I'm not a government official and not in charge of
That's
mandates.
what I mean.
Yeah.
I want people to go by the science, not politics.
Right. Exactly. Here's what I would say. So if you look at just the numbers, right, let's focus on the data that's out there. We do not have enough documentation of vaccine-related deaths to even hit a statistical number. Whereas, as I just showed everybody at the beginning of this, we have people dying every single day from the virus. And at this point in time, almost all of those people are unvaccinated. And of the people who die from COVID who are vaccinated, almost all of them are immunosuppressed, either because of advanced age, because older people just cannot mount the immune response that younger people can, or because of immunosuppression from chemotherapy or other medications they have to take for underlying problems like rheumatoid arthritis and things like that. So, you know, not going to answer a mandate. That's somebody else's business. From a standpoint of personal choice, if you care about dying or landing in the ICU for 12 or 15 days with a $100,000 medical bill, get the vaccine. The numbers out there are pretty simple. I just read a recent study.
Saturday, I am going to a funeral of a 44-year-old guy who's completely healthy, and he passed away.
Yeah,
So,
it's sad. We have lost people in their 40s and 30s in this community to COVID.
Yeah, and then one more thing that I hear from most of the guys is why is there no talk about other prophylactic type medications like monoclonal antibodies, all that stuff.
Let me answer that for you. So two things. I know lots of things are out there. Sure, if you look on the internet, you can find any number of things that people say are going to work for this. As of today, the only thing under an EUA from the FDA is monoclonal antibodies. I know there's stuff out there about ivermectin. Ivermectin may end up proving to be beneficial. More studies are needed, and that needs to be put through the same rigor that the vaccines have been put through and that monoclonal antibodies have been put through. If it comes to the point that ivermectin is shown to be that way, I will I will become an ivermectin proponent. At this point in time, I have done a ton of research on ivermectin, and the data out there is not yet strong enough to support it. More research is needed. Monoclonal antibodies, okay? These just came about with approval for prophylaxis. So this is post-exposure prophylaxis last month. And the supply chain of those things is not at all prepared to treat people. Additionally, the prophylaxis for that only lasts a short period of time. So whereas the vaccine prophylaxis, we now have data of it lasting out nearly a year. For monoclonal antibody prophylaxis, we only have data going out a few weeks to a couple months. And so number one, we just don't have the supply to be able to do it. And number two, the data is not there yet to show long-term benefit.
And okay, well, thank you. And then you know, I received the Pfizer vaccine. I had no side effects, and I've been exposed to it a couple times, and so I mean, I'm pretty confident I made the right choice. But I mean, everybody has to make their own choice. But those are the two things that I hear most from people when they're concerned about, you know, why is it being pushed so hard when the survival rate is so high.
Sure.
Thank you.
You bet.
Thanks,
All right,
Larry.
who's next, Brittany? And I can
So-
run a little longer. If your team can, I'll go a little bit longer for this.
Yeah, I'm okay as long as everybody else is okay. All right. So we do have some more. Josh stating you are next in the hands up category. So. Josh.
Yeah, sorry about
Take
that.
a while to find the unmute button.
Yeah.
That's fine.
Meadows, I have a question. I know of an individual that has a heart problem, and they've been instructed not to get this vaccine by their doctor. They've also been told that if they tried to get the vaccine, they have to have a specialist and a heart doctor present and have to be in the hospital in order to get this vaccine.
Okay, well, not knowing the person's exact condition, I'm not going to be able to comment specifically on that. However, here's what I will say. There are no cardiovascular-based contraindications to the vaccine. So I don't know the exact rationale for the advice that person has been given. I will say off the top of my head, I would struggle to understand giving that advice, and cannot think of a good reason why someone with a heart condition would not want the vaccine. We know from the data that's out there that having a heart condition is another risk factor for a poor outcome from the COVID infection. With all things, it's a risk of pros and cons, you know, the benefits and the risks. But I personally cannot think of a good reason why a physician would give that advice.
So who does an individual contact for somebody else different to get an opinion on that?
You know, my advice would be to contact the health department. Would be the first thing. They have access to vaccines and can certainly do that, and they could always seek the advice from another primary care provider. And again, you know, not all physicians are 100% on this. I'd say about 99% of physicians are going to offer the same advice that I'm offering here today, but there certainly is a small contingent of people that have differing opinions on this.
Okay. And then the other thing is, I know an individual that has had the vaccine, and they've been in and out of the doctor getting some steroid shots to control some rash and hair loss and some stuff that has come about ever since they've got the vaccine. They've been told that the doctor says that this escalated because it basically boosts your immune system more for this kind of stuff. So
yeah, good question. Listen, the rate of side effects for vaccines are very low. It's not zero. So like anything, there is always at least a small risk in doing anything, and that includes taking the vaccines. Each person's immune system works a little bit different, and certainly there are going to be some people who have an unusual reaction, though again, based on the data that's out there, that risk is far less than 1%.
Okay. That's all I got.
Okay, thanks, Josh.
Thanks, Josh. Okay, Brent Anderson, you are next.
So a lot of questions we get out here, and I know you touched on natural immunity a little bit, and you said that it's about the same level as getting a vaccine.
Yep.
A lot of questions we get out here is why has not natural immunity been looked at more on a national scale, and only when it comes to like vaccine mandates. If somebody who already been prior infected, why is there such a push for them to get it again? Knowing that there is some benefit to it, getting it again, but if it's just the same level of protection, why is that not more considered
Sure.
nationally?
Yeah. So listen, I cannot answer from a policy standpoint, why proof of immunity is not considered in the options that are there. I can speculate on some reasons why we would favor the vaccine over proof of natural immunity. So one, early on and probably certainly within the last few months and before Delta, I'm not sure if this is still the case, there were many reports out there of people purposefully getting infected with COVID to try to gain the immunity as their way of gaining immunity. When you compare the risk of the vaccine versus the risk of infection, clearly there is a much higher risk with natural infection. Okay, so the likelihood of a bad outcome from a natural infection is substantially higher than it is with the vaccine. I suspect that some of the rationale put into saying get the vaccine rather than base it on immunity is that some people would use poor judgment, thinking that they would trust getting the infection over trust getting the vaccine. That would, from a pure statistical scientific standpoint, that would show very poor judgment on the part of those people. But I think the concern from those setting policies is that a high enough percentage of people would do that it would fill up our hospitals even more than they already are.
All right, thank you. Derek Redline, you're next.
Okay. Can I be heard?
You can.
Okay. Transmission, both vaccinated and unvaccinated people are able to transmit this still, correct?
That is correct. Yeah, that's a great question. So here's the data on that. If you are vaccinated and you get exposed to the Delta variant, and just for everybody to know, almost all of circulating COVID now is Delta variant or a new variant called the Mu variant that's still being studied. They sample roughly 20 to 25% of positive infections and do genotyping on them to track this, and each state tracks this. In Washington State, again, it's about 23% of cases are sampled. With the Delta variant, if you're immunized, you're about 40 to 50% less likely to get the infection than if you're not immunized. Okay, when you get the infection, you have the same ability to transmit it as somebody who is not vaccinated. Those viral loads are the same between people vaccinated and unvaccinated. The likelihood of landing in the hospital, landing in the ICU, and dying, again, is substantially less if you are vaccinated than if you are unvaccinated. So the reason for the mask mandate after, despite vaccination, is because of this transmissibility. So many people, if they've been vaccinated and they get exposed and get the Delta variant, they don't feel all that sick. They feel like they just had a little cold or some allergies because the vaccine worked. From that standpoint, they're not seriously ill. But unfortunately, they can still transmit it, which is why it's so important for everyone to still wear masks, even if you've been vaccinated.
Mhm. The Pfizer FDA approval, did that come based upon the original research involving the Alpha variant or the Delta variant?
It included both, though I think the studies have been ongoing. They started early, but they continue. So those same cohorts of people, don't quote me on this, I think it's around 45,000 people in the initial study are still enrolled in that study, and we get ongoing data from that. So it combined both. The FDA approval was a 360,000 page submission.
And I think right now my last question is just for your medical staff. Do you know a ballpark estimate of what your medical staff is as far as vaccinated and unvaccinated, and the reasons they might not be?
I don't, unfortunately. Here, I'll tell you why I don't. That has been considered some protected health information from a standpoint of going down to the individual level. That is changing now with the mandate, but I don't yet have fully accurate data on that today.
Okay.
Hope to have that soon.
Yep. That was it for me. Thanks.
All right, Jonna, you're up.
So this is Jonna and Clay here. The question I have is, I have an employee who had a vaccination several years ago, and he suffered from, I may pronounce this wrong, Guillain-Barré syndrome.
Oh, Guillain-Barré, yeah.
Okay, thank you. And the doctor has recommended that he doesn't vaccinate due to serious life-threatening conditions. Do you know, if you're familiar with that, can you explain what that means and why it's life-threatening for him?
Well, so with the Guillain-Barré, I believe that the only vaccine with that as a contraindication is the Johnson & Johnson. I certainly can provide more information afterwards. With flu vaccine, there was a dose. Gosh, I think it was sometime in the 70s. But there was one dose of the flu vaccine that came out decades ago and caused Guillain-Barré in many people across the country. They changed the formulation after that and found it safe. But with Guillain-Barré, which ends up being a neurologic condition, there is a risk with future vaccination with the same vaccine as you've had before. I believe from a warning standpoint that only exists for Johnson & Johnson, but I certainly can look that back up and provide that information to Brittany.
Awesome, thank you.
You bet.
Rich, are you still okay? I got two more people that have questions, and I got one more question in email.
Yep, sounds good. I'll stick around for it.
Okay. David, you're up. David and Square.
Hi, my question is, what are your thoughts on pregnant women receiving the vaccine?
Yeah, great question. We get a lot about this. So this has been heavily looked at. Obviously, we don't have quite enough data on the vaccine from a length of time to know, to have this tracked out all the way from the beginning of pregnancy to the end of pregnancy. Certainly many women at any point in their pregnancy have gotten the vaccine, and so we have that data combined, but to track a single person all the way through, we don't have that. The overall rates have not shown any increased risk of poor outcome for mom or baby with the vaccine. And so at this point in time, the American College of Obstetrics and Gynecology has fully endorsed this for their patients. There is some very good data out there showing that women who do get vaccinated during pregnancy are able to transmit some of those protective antibodies to the infants at the time of birth that then protect these infants against COVID, because obviously we don't have vaccine approval for young kids yet. So it offers some protection both to the mom and the baby. There are some early, and this is early data showing, and the study I'm referencing is actually out of the state of Mississippi, that there is a substantial increased risk of fetal demise, so death of the baby in utero before birth in unvaccinated women. More research needs to be done on that to determine if that risk is statistically significant. But we are seeing some trends of, unfortunately, stillborns and fetal loss in unvaccinated women who get COVID. So at this point in time, definitely recommend this for pregnant women. Pregnancy is a risk for poorer outcomes of COVID because your immune system does change during pregnancy due to having a baby in your body.
I have a quick question.
Sure.
Does this mean I'm going to be a grandpa, David?
That's Larry.
Next question.
Next, Kamali.
Yeah, this is Michael Paul. Tell us about long-term side effects and how could the medical community be confident in the lack of them, or especially with the mRNA technology?
Sure. Yeah, I'm happy to address that. So first, just from a basic standpoint, so historically, looking at vaccines over the long term, we have very few examples of long-term side effects from vaccines. Guillain-Barré is one of those examples out there, but otherwise, if you look at the history of vaccines and how they normally work in people, we rarely see long-term side effects. Most of the side effects that happen are immediate. They happen within the first 15 to 30 minutes, and certainly usually within the first 24 hours of time. By 2 weeks, almost everything from a vaccine side effect has resolved, with some rare examples like Guillain-Barré in limited settings. So first, I would say that obviously we need more data, right? The vaccines have not been around long enough to look at them long term to be absolutely certain that there will not be side effects. Like all things, I think these decisions are about weighing the pros and cons. What has become very obvious in growing rates is long-term COVID. It might be called long hauler syndrome or long COVID, but a substantial number of people who get COVID, the infection, have long-term illness. So chronic fatigue that doesn't resolve, chronic difficulty breathing, heart conditions, arrhythmias that happen from it, long-term neurologic side effects. And so if you look at the data so far, how long has COVID been around, and people that we now see with long-term COVID side effects versus how long the vaccine has been around and any evidence of side effects to date from the vaccine, the risk again is substantially higher with the COVID infection than anything we've seen with the vaccine. So can I tell you that the vaccine is not going to cause with 100% certainty any long-term side effects? I cannot tell you that. Can I tell you that the risk of long-term side effects with the COVID infection is substantially higher than the virus? I feel absolutely certain of that.
All right, Tyson, you're up.
And by the way, we have no treatments for long COVID. There are no known treatments for that.
Yeah.
Hey Doc, appreciate your time and
Sure.
You answering Q&As. First of all, do you have any children?
I do. I have a 13-year-old son and a 9-year-old daughter, and my son is vaccinated, and my daughter will be as soon as it's approved for her age group.
Okay, that answers my question then. Thank you.
Okay.
Ben, you're up. Hipkey.
Okay, and there's my daughter right there.
Can you hear me?
I can.
Yes.
Hey, thanks for doing this. As you've said, natural immunity is comparable to the protection that you get from getting the vaccine.
That's correct.
It seems to me that working on the front lines for 18 months, the medical community has had certainly more exposure and likely has a much higher rate of natural immunity than the general public. I'm wondering, is that being
Actually,
taken into account?
Can I respond to that?
Yeah.
On that, the answer is no, actually, and I'll tell you why. And that's because the medical community followed all of the infection prevention guidelines. So we've done some internal studies in Providence with antibody rates in our employees, and in that we actually, as a healthcare industry, have a much lower rate of natural immunity than the average population because of how strictly we've followed infection prevention guidelines.
Have they done antibody studies in the general community?
No, but we have for the medical community.
Okay, because I've got my antibody tests a couple weeks ago, and I have strong antibodies. I'm wondering if that is considered comparable to vaccination immunity. Will there be exemptions for someone who is medically protected? So
listen, I can't speak towards policies on this from a purely medical standpoint. Natural immunity is comparable to vaccine immunity. From everything I know in reading the mandate, because obviously I have to know this for the employees that I have here at Cadlick, it's not accepted. So it's not something they're taking into effect. And again, rationale for that I can only guess upon. So I won't put that out there more than I already have. But it's not currently accepted. And again, I will state, we have very good data to show that if you get the vaccine after natural infection, your protection is about 2.5 times that of either thing alone. And from some research done in Nature, the ability of your memory cells to respond to future variants is likely substantially increased by getting that vaccine after you've been infected. And so whatever the next awful variant is out of this, getting that immunization after natural infection is going to give you a higher likelihood of being able to fight off that new variant.
Okay, thank you.
You bet.
Thanks, Ben. All right, Jeff Grady.
My question is, they're talking about the third shot or the booster now with, the different or second, I guess, the Johnson & Johnson. What's the thoughts on that? And then can you go over that just a little bit, please?
Sure thing. So I'll break it up into a couple different categories on this. So the first category is for people who are immunocompromised, and that is currently approved. And so for anybody who has an immunocompromising condition or whom is taking immunosuppressant medication, very good evidence that a third dose, a booster dose, is warranted. They do not yet have recommendations for the Johnson & Johnson with that. More data is needed. The reason for that is if you are immunocompromised, your immune response to the vaccine is reduced. Okay, so you don't make as many antibodies. Your body does not learn to produce those antibodies as well as somebody who's not immunocompromised. So that's a definite. Regarding a third dose for others, I know there was an announcement on that was premature and didn't include approval from CDC or FDA. They continue to research that, and from everything I've read, what they're weighing is we need to figure out which groups of people are going to benefit more from getting that third dose, that increased immunity, versus which group of people are likely to have a higher side effect profile because they already mounted a substantial immune response to the first 2 shots. So that's why they're still holding off on an overall recommendation for everybody to get that third vaccine. It's not clear yet whether that will be out there for everyone or if there'll be subgroups of people that a third vaccine is recommended for.
Okay, thank you.
Okay, guys, any other questions out there? Now's the time. Okay, and if you have questions afterwards, you can email me and then I can reach out to them. Oh, Cody Roberts.
So, thanks again for your time. I think you've kind of touched around my question a little bit, but just so I understand a direct answer, because I get asked a lot. If people that are vaccinated can still catch and transmit COVID, then how does my vaccination status impact anyone other than myself?
Sure. Yeah. It's a good question. So the first direct answer is, again, if you are vaccinated, you're about 40 to 50% less likely to get that Delta variant infection than someone who's unvaccinated. So there is a reduced risk of getting it in the first place, which then, of course, means you're less likely to transmit it. The other factor that goes into that is really more of a personal factor as opposed to a community risk. So that the reduced risk of infection is both a community and an individual factor. From the individual factor, if you are immunized, you are far less likely to end up in the hospital, and you're almost guaranteed to not land in the ICU. That does have an impact on the community in that, unfortunately, our ICUs and our hospitals are so full that we can't take patients who have other conditions.
Okay, thank you.
You bet.
Okay, Jana, you have one more question?
Me and Clay do, yes.
Yeah, so I have another question. Are you familiar with, and I'll probably screw the pronunciation of this up, is it parosmia? Parosmia? Are you familiar with that, Doc?
I'm not familiar with that. You want to describe it to me, and I'll do my best to answer.
As I understand it, parosmia is something that can happen after COVID, specifically related to loss of sense of smell or taste.
Oh yes, yeah, like anosmia.
Right.
It happens. Yeah.
Recommendations for those that are. Do you have any recommendations for those that are experiencing that and are trying to help themselves get their smell back? Is there anything that you've heard of that is helpful in that regard?
No, unfortunately not. I've not seen any data out there showing anything that can be done to help recover that sense. Probably one more reason to go get your vaccine.
Okay, thank you.
You bet.
Larry, got one more? Or not?
Might just need time to find the mute button.
There you go.
Sorry about that. Can a person who's vaccinated host the virus and actually spread it without knowing you're spreading it?
Yeah, so anyone can get the virus and have minimal enough symptoms that they don't know they're spreading it. So that's happened in lots of people. Again, in some people, the natural infection, even without vaccination, is going to be very mild. They're not going to feel overly sick, and they unfortunately probably are a higher risk of spreading that to other people just because they don't realize it. The same thing can be true in a vaccinated person. So that risk exists in both. I am unaware of, I think what you might be referring to is like a carrier state, which is something where you have a long-term infection that you transmit to people without knowing it. I have not seen anything suggesting there are any long-term carrier states in COVID.
Okay, thank you.
You bet.
All right, so we've gone over and doubled our time. So we really appreciate Rich talking to us and taking the time. And we really appreciate what you guys are doing for our community. So I know everybody's tired and overwhelmed by this stuff. So keep up the good work. And we really appreciate you taking your time out of your day to answer our questions and help us understand this a little bit better.
You bet, my pleasure.
All right, guys. Thank you, everybody, for calling in, and hopefully all your questions were answered. If not, let me know, and I can shoot them to Rich, and then we'll go from there. So with that, everybody have a fantastic day. Be safe. I'll see you later.
Thanks, everybody. Bye.
Thank you, Rich.
Thank you.